I'm here with Dr. John Prunskis, Chief Medical Officer and Principal at DxTx Pain and Spine. Dr. Prunskis, I'm glad to talk to you.
Glad to be here. Thanks, Mike.
Can you tell us a little bit about your background and what motivated you to get into interventional pain?
Sure. So when I was doing my anesthesiology residency at the University of Chicago, they had just started a interventional pain program. And at that time, it wasn't as advanced as it is right now, but I went on to get some further training during my fellowship. And then when I went out into private practice, there was a demand for my services based on the training that I had for people who had various painful conditions. And so that's what started it. And I at the time of my residency training, I didn't know that I was going to be doing this full time, but it evolved into that.
Great. You talked about painful conditions. What are the most common conditions that you're presented with your patients?
So mostly what we see is something related to the spine. So it could be low back pain, it could be neck pain, sciatica, pinched nerves, arm pain, but anything musculoskeletal, so with the joints, et cetera, is very common. About 20% of my practice is headache pain. And then there's various other pain problems, such as pelvic pain, both for men and women, chest wall pain, after, of course, they've seen a cardiologist and it's not related to their heart, and then various other painful conditions that may be associated, for example, with diabetes. Some diabetics have what's called diabetic neuropathy, and that can be a very painful condition of the nerves where their feet, for example, are always in continuous pain.
Pain management has made a lot of strides in the last few years. Are there specific treatments or procedures that have you excited?
Oh, it's unbelievable, the explosion of data in what we call the interventional pain space, because people can also use the word as pain management in the sense of just having a psychologist or a psychiatrist help them manage the pain. But what my specialty is interventional pain management, and that's where, in the majority of cases, we can identify a structure or structures that we can fix non-surgically and then eliminate or substantially reduce their pain. There are, of course, some painful conditions that affect the whole body, which then there are other ways to treat. But I'd say about over 90% of the painful conditions that patients see us for are those where we can identify, as I said, certain structures within the body that can be fixed. And now there's so much new data with technology and information just rapidly growing that we can actually sometimes put in very tiny devices or things like that sometimes are reversible, they can come out. But there's so many things now that we have available to us just to correct, again, without a major surgery, without any big incisions and all kinds of structural changes to successfully eliminate or substantially reduce the source of someone's pain. And so that's what makes it super exciting. And, I know that in my specialty, when I see a patient for the first time, I know that they're at their worst. Sometimes they've been in pain for a couple of weeks, but sometimes it's been a couple of years. And it is extremely draining and debilitating. But as I said, then as I see them after a few visits and their pain is better and better, and I get to see their true personality come through, it's extremely gratifying.
I bet. Are there any specific procedures that you find particularly encouraging?
So there are multiple procedures that are encouraging. So right now, neuromodulation is a very exciting space. And that's where we can take a very tiny device that is about the size of the tiniest piece of spaghetti you ever saw, and you can put that through a needle without an incision into the epidural space. You can put it over certain nerves, and a small amount of stimulation is then provided, which eliminates the pain from that area. There are also procedures where before there'd have to be large spine surgeries done because nerves were getting compressed. And we can sometimes put small devices in just to get the compression off the nerves to reduce the painful condition. And everything in general, if I had to kind of summarize it, is things that we didn't have solutions for even as recently as a year or two ago, we now have solutions, and those solutions are more and more minimally invasive, where patients go home the same day after their pain treatment.
That's great. That's really encouraging. As a thought leader in the interventional pain space, can you talk to some of the industry tailwinds and headwinds that?
Sure. So I think as far as tailwinds, the explosion of data and technology is allowing us to successfully provide solutions for painful conditions and diminish the opioid use and prescribing opioids. With regards to things that are headwinds or things that are inhibiting that, is a lot of it goes around how the federal government is continuing to decrease reimbursements, which doesn't make any sense for some of these procedures, and especially in the face of rising inflation. So if a physician can't provide a certain procedure because it's more expensive to provide that care, then what's left? You just have to continue to write opioid narcotic medications, which nobody wants in the face of the opioid crisis that we have. The other thing that is, I'll call a headwind, is there's increasing amounts of bureaucracy now in healthcare, and that goes along with the electronic health record, which is now used widely because many people don't know that as a result of Obamacare, hospitals have to use these records, which many people know are extremely cumbersome and don't provide, and in many cases, detract from the value of care and the efficacy of the care to patients. So on the plus side, advances in data and technology, and on the minus side, just nonsensical cuts in reimbursement, as I said, especially in the inflation we're having. And then also we see that Medicare replacement policies, which by law are supposed to provide the same care as a traditional Medicare policy, do not. And so when someone walks into my office with a Medicare replacement policy, many times there are procedures that if they had straight Medicare, I could do the procedure to eliminate or reduce their pain. But because they have a Medicare Advantage policy, or in many cases I call them a Medicare Disadvantage policy, that through marketing and advertising, these elderly folks have signed on to these programs and unfortunately can't get the care that they really need.
Yeah, it's very interesting. We know that you're obviously still a practicing physician, but also the chief medical officer and principal of DxTx Pain and Spine. Can you talk a little bit about the philosophy and how you came about wanting to go on that with this type of platform?
For the majority of my career, I was a contrarian. And what I mean by that is for over 2 decades, I and my team and Dr. Terry Dallas Prunskis, who started Illinois Pain and Spine Institute with me, we did not agree with the then conventional wisdom, which has now been discarded, where physicians were taught, where articles were written, where textbook chapters were written, that if a patient has a painful condition and you prescribe narcotic opioid painkillers, they won't get addicted. That never made any sense to us. But as I said, for over 2 decades, that was the conventional wisdom. And so I'm a national speaker, and when I would speak to hundreds of doctors in the audience, there would also be other speakers on the platform with me who would tout it's okay to write prescriptions for narcotic painkillers for people with pain because they won't get addicted. And that, again, made no sense. So when I would start my presentation to these physicians, I would say, I'm going to tell you I disagree with the previous panelists. But in the audience, because that's what they heard from so-called experts. That's what they read in their so-called peer-reviewed journals, where the industry and drug companies sponsor these studies, was that, no, it's okay to write narcotics. So 95% of the people in the audience would disagree with me, but I just kept to my, as they say, stuck to my guns and didn't change it because it made no sense. Well, as it turns out, these physicians who were frequently on the speaker's platform with me, who touted the opioids, wound up taking plea deals with the Department of Justice to stay out of prison because they were on the payroll of companies who manufactured narcotics and opioids. Similarly, the journal articles were industry sponsored, and people started to realize what I realized from the get-go, that if a company that manufactures opioids is sponsoring this article, there's obviously a conflict of interest, or sponsoring this so-called research. So gradually the pendulum started to swing, and I was invited by the team of President Obama to the White House, because even despite the fact that most physicians disagree with us, there was enough of physicians that appreciated what we did that we grew to be the largest pain practice in Chicago. I'm not saying it was easy, because frequently primary care physicians, this is back, 7, 10, 15, 20 years ago, sometimes would call and say, Dr. Prunskis, if you don't write the narcotics that my patient, should get, I'm going to find somebody else. Well, I try to explain to those doctors, no, we've got other medications we're using, we're diagnosing the problem, and we've got this. But that didn't resonate for reasons that I just talked about, because that was the common wisdom. Write narcotics, write opioids, they don't get addicted. So it was very difficult. However, as the opioid crisis became the number one healthcare crisis in the United States before COVID, and now after COVID, it's back to number one, where now we have well over 100,000 deaths per year. And you have to understand, it's well over 100,000 deaths, despite the fact that now nationwide, first responders carry the antidote for overdose of narcotics, Narcan or naloxone. If they didn't have that antidote, the deaths would be skyrocketing. But in any event, so I got called in by Obama's team, and they said, could you please explain to us how it is that you've got the largest pain practice in Chicago, you write the fewest amount of narcotics, your patients are getting better. What are you doing differently? And so I had some meaningful conversations with them and their team. And then when President Trump was elected, 2 weeks after the election, I got an invitation to go to Trump Tower in New York to talk to his team. Also similar, what are you doing differently? We know about you. You've got a national reputation. What's going on? The pendulum seems to be switching to your thought process. And I explained that to them, and they offered me a full-time position with the U.S. Department of Health and Human Services, which I respectfully declined. But I said, because I would have to stop seeing patients and move to Washington. An opportunity then presented itself where there was a task force created of leaders within their specialties who were experts in this space. So there were members from orthopedic surgery, emergency room physician, pediatrics, oncology, Department of Defense, departments of Veterans Affairs, psychiatry, addictionology, etc., where they created a blue ribbon panel of national experts who already had this interest in effective diagnosis and treatment of painful conditions, and they asked us to come up with the national guidelines. This project was more work than I thought it would be. However, in the years that I was a White House presidential appointee and worked on this project, we came up with these guidelines, which are about 140 or so pages long. And once we wrote those guidelines, you then submit them to the general public, and you have to see who endorses those guidelines. And 100% of medical specialty societies endorse those guidelines, not 99%, 100%, which means that they said this is the way pain should be diagnosed and treated. So this is a long answer to your question, but I have to set the foundation. And so with having then the largest practice, a pain practice in Chicago, with for over 2 decades disagreeing with the common wisdom of right narcotics, don't worry, they won't get addicted, getting recognized at literally the highest levels of government and healthcare in the United States, it then put a larger spotlight on me and my team, where then people came to us and said, we would like to help you and build your company, et cetera. But there were always some issues or problems that I didn't quite agree with their vision. And so finally, my son Owen, who was a applied mathematics major, and he was in college, and then he was attending Harvard Business School at the time, he said, why don't we just do this? And so he dropped out of Harvard Business School to help on the business side of it and to get this to fruition. And then with my technical medical expertise, we had as the absolute foundation is the best patient care to fix the source of the problem. That's why our name is DxTx. Dx is a medical abbreviation for diagnosis. TX is a medical abbreviation for treatment. So diagnosis and treatment, pain and spine, because that's what we do, or most of the areas where we focus in. And that's the foundation. But then secondarily, what we also saw is there was an erosion of respect for physicians. And what I mean by that is many physicians are now employed by hospitals, or they are regulated by insurance companies. And we saw that was actually not benefiting the patient. So our second tier, after we get that foundation of excellent patient care, is respect for the physicians, and then respect for the teams that are part of our program. And that, along with medical management, making sure that all the bureaucratic issues that are now, as I mentioned, escalating, are handled, and so that by non-physicians, so the physician can really focus on helping the patient and not on the extraneous activities, and know that that physician is highly regarded, which we have identified as what's going to be best for the patient as well.
I know there's many practices in the United States that want to affiliate with DxTx, but they all don't, and usually it's not their decision on that. Can you talk a little bit about what type of practice is a good fit for DxTx Pain and Spine?
Sure. So you're absolutely right. So one of the most surprising thing to me as the chief medical officer and platform for DxTx is the variability of pain practice in the United States, the variability of how diagnosis is made and what treatments follow. I was absolutely surprised and continue to be surprised, because I thought that we read the same journals, we go to similar meetings. However, when the physicians go back to their practice, what they implement in their practice, more often than not, is not consistent with the U.S. Department of Health and Human Services guidelines that we've talked about previously. And so when we go visit a practice to assess whether or not they would be a good fit for our model, we're not looking for perfection, because, again, as I mentioned, there are so many what you called headwinds or difficulties now in the practice of medicine. It's virtually impossible to cover all the bases and still practice medicine well. The doctors being pulled in many different directions. But if we identify certain criteria of, level of training, how they interact with their staff, coding accuracy, how they're prescribing narcotics and opioids, and very importantly, a willingness to accept that they don't know everything, and a willingness to be open to change if we can demonstrate to them through data and processes that there's a better way to care for their patients. So when we see a practice and we know we're going to see weaknesses, we just want to make sure that the physicians in that practice are not doing something that is so egregious that that we wouldn't want to touch them. There's also then a middle ground where they have problems where they're not prepared to be invited to DxTx, but we can help them on a consulting basis, get them to that level, help repair, fix some of the issues that, due to this extreme complexity in the way pain care and all the bureaucracy around it has to be rendered. And if we get a group like that is kind of in the middle, we help fix them to a point where then we can invite them to affiliate into DxTx.
Great. Well, Dr. Prunskis, always a pleasure talking to you.
Likewise, Mike. Thank you.
Thank you.